Hi PTA students, this is Loretta and I am going to talk to you about goniometry today. So we will go over this in the first lab and we will go over specific measurements and what you're going to be tested on in your skills checks. The skills checks in this lab are going to be fairly informal. You're going to have plenty of time to practice, and I will be going around in the lab checking you off on two random goniometry tests which you will draw. And so you should be familiar with the list in the downloads of all of the measurements that you will be responsible for. You will get a chance to practice those in the lab before you are tested on them. So during our first lab weekend we will not have any skills checks. We will have a short quiz. The information on that quiz will be based on the objectives in the lecture material and some of what is in this lecture. It's going to be very basic, really just the basic information about goniometry. So during the lab, besides the quiz in the first lab, we are going to look at joint range of motion and goniometry, how to assess it. We're going to go through upper extremity, lower extremity, spine measurements, and we're going to practice them. You will also have a little bit of time to practice them in the second lab while we are doing skill checks. So practice is important for getting good at any skill. If you practice your goniometry, you will get better at it. One of my classmates that I went to school with, who now works at the main campus of the hospital where I work at another campus, she was talking about goniometry and she says, hey, remember when we learned that at the beginning of the program and how difficult it seemed and how much we worried about it, and then by the end of the program it was nothing. It was a piece of cake. So just know that you will practice it, you will get better at it, and you will get to where you feel very comfortable with it. And that is really what I hope to have happen. You should all have your own goniometers by now, and if you don't, let me know and we'll make sure that you have that. But you should practice at home. Take that list and practice every one of those measurements. Practice on your friends, practice on your family, practice on your coworkers, practice on yourself, although some of them it's not all that easy to do that. But I guess that's my whole point, is practice a lot. Okay, so when we talk about joint range of motion, we are going to talk about different types of range of motion. So the first kind of range of motion is active range of motion. That's the movement of a segment within the unrestricted or available range of motion that's produced by an active contraction of the muscles crossing the joint. Meaning, the patient is moving the limb themselves. It's active. What can they do by themselves? Okay? Active assisted range of motion is a type of active range of motion in which the therapist or another outside force like the wall or one of those chairs that lifts you up assists the prime mover muscles to complete the motion. So in 110 with Jamie and Patty, you are going to be talking about active assisted range of motion and how do you do that in a treatment setting. So we're not going to be talking so much about that, and in goniometry we really do not use active assisted range of motion all that much. But if you do, for example, if you measure someone's shoulder while they're sliding their arm up the wall, measure their shoulder flexion, you would document that as active assisted range of motion because it's not passive. You're not doing it for them. It's not active. They're not doing it entirely by themselves. It's active assisted because the wall is helping them lift that up. And you will find that, especially after a shoulder injury, people have more active assisted range of motion and more passive range of motion than they have active range of motion. So passive range of motion is a lot of times what we are measuring with goniometry, even though we still do measure active. But passive range of motion is the movement of a segment within the unrestricted or available range of motion that is produced entirely by an external force with little or no voluntary muscle contraction. So the patient has to relax in order to get a true passive range of motion. That I tell people all the time. That's probably the hardest thing we ask anybody to do in physical therapy is, hey, relax while I move your injured part. But in order to get a true passive range of motion measurement, they really do need to relax, and you need to do the movement. We talked about end feel in kinesiology, so it's the feel or the sensation of the extreme end of passive range of motion, and it reflects the tissues or structures that limit the joint motion. So it could be physiological, such as soft tissue approximation with knee flexion, for example, where the soft tissues are coming up against each other. It could be pathological, such as swelling, and that's what's preventing you from getting more range of motion. So all of the end feel motion, all of the end feel information that you learn in kinesiology, hey, it's going to come in handy in this class. So I will expect you to know what the normal end feel is supposed to be, and to be able to report what a pathological end feel is. For example, you might document after your goniometric measurement that the patient had 170 degrees of shoulder flexion with pain at end range, or something like that. Or you could say they had 120 degrees of shoulder flexion with an empty end feel, meaning you never got to the end range because they said, ow, 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 stop bending my arm, or something like that. So you documenting end feel as part of your joint range of motion documentation is really important. So if you say someone's joint range of motion is within normal limits, that means they have no pain at the end of their range of motion. That's normal. It's normal to have no pain. So end feel is very important to document. Sometimes you'll feel somebody's arm and you'll say, okay, they've got good range of motion, but what is going on in that hip? It's not normal. So you document your end feel to distinguish between physiological normal end feel or pathological, something different is going on there. So when do we not perform goniometric measurements? When is it contraindicated? So usually I talk about contraindications and precautions. In contraindications, I mean absolutely don't do it. It's an absolute contraindication. Precautions are sort of relative contraindications where you might do it, but be careful. Okay, so absolute contraindications, you do not want to perform goniometric measurements when moving the body segment can disrupt the healing process. In other words, don't rip open someone's stitches to get a range of motion measurement. I mean, of course, I know you would never do that, but if they have restrictions on motion, sometimes you'll get someone after a tendon repair or something like that, and the doctor has said, please do not exceed 0 degrees of external rotation. Okay, we are not going to measure their external rotation until they're cleared for that motion. Okay, if they have a subluxation of a joint, a dislocation, or a fracture, of course we're not going to do goniometric measurements, because how accurate is that going to be? Myositis ossificans, which is calcification of the muscle, it's common in certain conditions like spinal cord injuries. There are other reasons why you might have it. That is certainly going to affect your range of motion measurements, and you can actually injure the muscle, so you don't want to perform it when you have that present. If someone just had a surgical fusion or fixation, heck no, we don't want to measure it. We're just going to note that in the chart, you know, unable to measure joint motion because of blah, 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 whatever contraindication we have. So precautions, so they're relative contraindications. So it might be a reason why you don't perform goniometry, but it might be that you do it anyway with care and attention to what's going on with your patient. So if someone has moderate to severe pain with the movement of segment, and moving it may aggravate that pain, well, we don't want to do any harm, right? That's number one. We don't do no harm. We don't want to harm our patient anymore. If they're in so much pain that you can't move their arm or leg without hurting them, don't do it. Make sense? Okay, if someone is has got a really inflamed joint or joint region, they're in a highly acute stage, they 2 days after surgery, something like that. You might measure it, but you're not necessarily going to do like a full passive range of motion. So that's where your precaution comes in. If somebody has osteoporosis or a recently healed fracture where the bone may still be weak, you want to be super careful with passive range of motions. You do not want to break somebody's bone or break it again. So that's something you want to be gentle with those people. If someone has a hypermobile joint, do you think you want to press them into more mobility? No, we don't want to do that. Their ligaments are probably already stretchy enough as it is, and we don't want to make them worse. We might do an active range of motion and note that they still have available motion in the joint, something like that. But a hypermobile joint, you got to be careful with those. If someone is in the acute stage of a soft tissue injury, say they have a muscle tear or something like that, I still remember when I was first out of school, I was in an outpatient clinic. There was a guy with a deltoid tear, and you could barely touch him without him hitting the ceiling. He was in so much pain. So you could do range of motion on him, but you wanted to be super, super, super gentle. So let that soft tissue injury heal before you start measuring their joints. After someone has had a prolonged immobilization of a part, for example, someone who has a proximal humeral fracture and they've been in a sling for the last 6 weeks, well, we're not going to bring them into the clinic right after that and put them into full passive shoulder flexion and see what happens. We want to be really, really careful with that. So after prolonged immobilization, they're going to have a lot of soft tissue shortness, they're going to have a lot of stiffness, and we want to be super careful with any movements we do to them. Okay, so our most used tool in goniometry is the universal goniometer. It's all of you are probably holding one in your hand right now, or you've seen them, or you see them at the clinic every day. But the picture right here is of the classic universal goniometer. We've got our stationary arm and our movable arm, the axis right in the middle. There are some with a 360-degree measurement. There are the small ones with the 180-degree measurements. You'll see some larger ones with 180-degree measurements. Usually using the small goniometers is better for small parts of the body, and the large one's better for large parts of the body. That makes sense, right? So all this should really make sense. Goniometry is very common sense. If I handed you a goniometer and I said, hey, figure out how to use this, with the knowledge that you have from kinesiology right now, you should pretty much be able to figure it out. So it's not brain surgery. So the little goniometers, one of the beefs that I have with them is the numbers are tiny and I can't read them. So I only use them if I absolutely have to. That's just a personal preference. You will find that you have your favorite goniometers as well. So the other great little tool that we use often for objective measurements of joint angles is a tape measure. A lot of times for trunk motions, it's a lot easier to measure the distance between two landmarks with a tape measure and then how it changes when the patient moves than it is to measure, for example, lumbar flexion with a goniometer. Certainly you could do it, but there are a lot of other motions involved, and the tape measure gives us a more accurate and repeatable measurement, and that is something we'll talk about a little bit later, but being accurate and repeatable is very important. Okay, so there are a couple different other kinds of goniometers that are discussed in the Clarkson book. The OB goniometer or inclinometer, it's this cool little compass thing, and you strap it onto somebody's arm or their head, and they move, and it shows the measurement for you. We have a couple of them in the lab in Bellingham. I don't know if the Pierce lab has any. I'll try to make sure Margaret brings one down on the goniometry weekend. I have never seen one of those in the clinic. I'll be honest with you. I've only seen it in the lab. You might find a practitioner out there who has one and loves it, uses it all the time, but most of the time, just your standard universal goniometer is the go-to instrument for measuring. But we'll play with them in the lab just because it's fun. Okay, so validity and reliability. That's pretty important. There's a little discussion of it starting on page 17 in the book. Validity means that the measurement is a true representation of the value. It means that it actually represents the angular relationship between two articulating segments of the joint. So how valid is it? You know, it's just how accurate are your measurements? How well can you read the tiny little numbers on the goniometer? So we want our measures to be valid, and to a point we want them to be reliable, meaning that the measurement is consistent, it's repeatable, and it's reproducible. So when we measure someone this week, we measure them again next week. We're doing the same thing, and we're actually documenting whether or not they're improving. So reliability is important. So there have been a lot of studies on how reliable is goniometry. Goniometric reliability is maximized by standardizing a group of things. We use a standard measuring device. We use that universal goniometer or what your choice of device. We use standard positioning and landmarks. So all that palpating landmarks and everything that we did in kinesiology, it's so important because now we're going to put that into play. Find those landmarks, put them in the right place, and use a standard measuring device to measure them. We want to use a standard procedure for measuring them. For example, if you took a person, they walked right into the clinic, and you just measured them right off the street like that, do you think they'd have a different measurement than if you brought them in, put a hot pack on them, stretched them for 30 minutes, and then measured them? Yeah, probably so. So that's important that we kind of document what we do on that. It's not a bad idea to do a pre- and post-treatment measurement. So you get one right off the street. How are they walking in? Then you do all your treatments with them, and then you measure them again and say, hey, what effect did that treatment have? That's really important. But a lot of times, like after a surgical procedure, after a total knee replacement, something like that, the patient walks into the doctor's office after sitting for an hour at lunch or something like that, or sitting for an hour in the doctor's waiting room, depending on the doctor's office, and the doctor just whips out the goniometer and starts measuring them. They don't warm them up. They don't do anything. So the cold measurement is something. I mean, that's what they're walking around with for most of the day. But the point is that you are consistent in your procedure in the clinic every time you measure, and you document what you did. Having a consistent examiner is another way to make sure your reliability is good. However, in the real world, that's not always possible. As PTAs, we are never the consistent examiner because we're never the first person that measures them. Our PT does the initial evaluation, and they get the first measurement. So it is really important that you communicate with your PT on their procedures, that your clinic has standard procedures for measuring people, and that you sort of keep up to date on that. So in the clinic where I work, we have in-services periodically where we discuss manual muscle testing, goniometry, different things. How are we doing it? We're making sure that we're standardizing our procedures, that we're using standard notations to make sure that the inter-rater reliability is a little bit better. But in studies, it has shown that intra-rater reliability, meaning the measurement I take today versus the measurement I take tomorrow, it tends to be higher than inter-rater reliability. So the measurement I take today versus the measurement you take tomorrow, there's not going to be as much reliability between those two because there's going to be differences in the way we do things. We're human beings, we're not machines. So there can be as much as a plus or minus 5 degree difference between different examiners, even using standardized methods. So we're not carving any of these measurements in stone. We're just trying to get an idea of where people are. So the purpose of measuring joint range of motion is, well, at the start of therapy, the PT measures to establish treatment goals. So they're going to measure, like in the picture here, they're going to measure ankle dorsiflexion, and their goal is they want to increase their ankle dorsiflexion because it's going to improve the patient's function somehow. So most PTs these days, they want to link their goals to functional goals, and so your goal isn't just to increase ankle range of motion, it's to increase ankle motion in order to normalize gait or some other functional goal. So measuring pre and post treatment in the same session to measure the progress, like I was talking about earlier. You measure at the beginning of the treatment, you do all the things you're going to do to the person, you do all your interventions, and then you measure them again, saying, hey, did that make a difference? And maybe if it didn't, maybe it's time to change your interventions. So if you did all this, whatever you did to that person, you know, ultrasound, range of motion, joint mobilizations, exercise, whatever you're going to do, and it didn't make any difference in their range of motion, maybe we need to change what we're doing. So it's a good way to kind of gauge how the treatment session went. You also want to measure at the conclusion of therapy to document the patient's overall progress and the outcome of the entire therapy, the course of therapy. So a lot of times we're documenting because we're trying to meet specific goals that the doctor has after surgery. We're trying to meet functional goals. We're trying to meet personal goals that the patient has, like they need to be able to get in, on and off their boat. I've had a lot of those guys lately, the on and off the boat. It's summertime, it's boat season, so people really want to get on their boat, and so that's one of the a personal goal that a patient might have. So we're just documenting that, yeah, they have the range of motion, they should be able to do this thing. So here we go, documentation. What a great segue. So the reason we want to document, we want to provide objective data. This is the O part of our SOAP note. We want data that's measurable and reproducible. We want it in the medical record, in the patient chart. And that way we can sort of prove to, you know, the insurance company comes to us and says, hey, why are we paying for your services? And we're saying, hey, because I increased this patient's range of motion from here to here, or the treatments that I did. We want to provide evidence for progress or lack of progress. Sometimes you're thinking, wow, this person isn't making, or usually they are thinking, I'm not making any progress. A really good way to show them that, well, yeah, you are, is you show them, here's what your range of motion was at the beginning, here's where it is now, you've made a lot of progress. So it's a really good way to document progress. Sometimes you have to justify to the insurance company that the person is actually making progress in order to continue on with their therapy, and there we go, we have our objective data to do that. So if you measure someone in a position that varies from the standard position for some reason, so say for example, we usually measure knee flexion in supine. For some reason we measured it in sitting or in a different position. We want to document that. So in the Joint Gym program at St. Joe's where I work, Joint Gym is our outpatient 6-week therapy program for after joint replacements. Sometimes we'll run across people with their knee range of motion and they get terrible range of motion in certain positions. Like supine just does not work for them, and they get a much better range of motion in sitting. Some of it has to do with muscle guarding, some of it has to do with just people's individual pain, but or just their body geometry where they get a better measurement in a certain thing. So if we measure someone in a different position besides what our standard is, which is supine, we note that in the chart. We say this was measured seated with the person's foot on a skateboard or something like that. So you want to make sure, and the reason that we want to do that is because we want to be able to have reliable, repeatable measurements. So if one of my coworkers measured someone 2 days ago sitting in a chair, and then I measure them in supine and they get a much worse measurement, does that mean that they're not improving? No, it probably means that they'll get a better measurement sitting in a chair, so I'm going to try it sitting in a chair. So you just want to document all that stuff. If you do anything different from what the standard is, you document it. If you don't know what the standard is, hey, I think it's time to have a meeting and everybody in the clinic needs to get together and say what the standard is. So here it is, goniometry. This is what we're all talking about here. So there are a couple people in the pictures, and they're measuring different joints. Patient position. So we're talking about standardized positions. You want to make sure the patient is comfortable and well supported. If they need pillows or bolsters or whatever, to make sure they're in a comfortable position so they can relax for that passive range of motion, you need to do it. The joint needs to be in anatomical position to start with, so you need to position the patient so they can get in that position. The proximal joint segment has to be stabilized so you can restrict substitution motion. For example, if I have someone sitting in a chair and I'm measuring their knee flexion, a lot of times, especially if they're having pain, as they pull back, they get to a point where they're getting to the end range of where they want to go. They will simply lift their hip up off the chair, and hey, it seems like their foot's getting farther back and they're getting more range of motion, but they really aren't, because we don't have the proximal joint segment stabilized, the hip, and so they can substitute a different motion for that knee flexion. So you want to make sure that they're positioned in a way that movement can occur through the full range of motion unrestricted. So say that I have someone and they've got about 100 degrees of knee flexion. So I think, oh, well, it doesn't matter if I'm in a chair with a little rail that's blocking me, because they're not going to get there anyway. Well, maybe they will today, and so you want to make sure that if they had full range of motion, they're unrestricted, they can go through that full range of motion. You also want to put them in a position where you can get the goniometer placed properly in order to measure that range of motion. So for this course, you should understand that there are different positions to measure the same joint motion. I just talked about some supine or seated. You can measure someone in knee flexion with their feet up on the wall. You can measure them with one foot up on a step and they're bending forward into flexion. But in order to simplify and not just drive you guys crazy, we are going to practice one position per joint motion. We want to make sure we have enough time to cover all the material in lab. However, sometimes we have to think our way through the patient scenario and say, okay, this is not working for this patient. How can I do it differently? So even though you're only going to be tested on one position and we're only going to do one position in the lab, think about different ways that you might want to do it. So if the PT has previously tested the patient's range of motion, you want to replicate the position they use. So in the picture here, the woman has got someone in prone, and she's measuring their ankle dorsiflexion a lot of time, and in the lab we're going to be measuring it in seated. But hey, look at that, she's measuring dorsiflexion and it works just great. So for this patient, that might be the best position to put them in. So the procedure that I would like you to use every single time you measure range of motion with a goniometer is this. So first you're going to explain the procedure to the patient, and you're going to explain it in terms that they can understand. So if you're measuring a child, you want to explain it in terms they can understand. If you're measuring someone who speaks another language, well, get an interpreter because it's important. So you're going to say, okay, I'm going to measure your shoulder flexion range of motion. I'm going to have you lie down and like this, and I'm going to have you do this with your arms. You're showing it to them. You are going to look at what the active range of motion is on the uninvolved side as well. And you're going to look at what it is on the involved side. So this is just a general scan. You're not measuring all these necessarily. You might just say, hey, go like this with your arms, and they go like that with their arms, and you are kind of looking, wow, is the right side less than the left side? You're just kind of eyeballing it. Okay? So then you're going to go through passive range of motion. You're going to assess the end feel on the uninvolved side. So what if this person just has tight shoulders and they have this like really super, super firm end feel at 150 degrees? Are you going to expect them to get to 180 on the involved side? Of course not. So if you see what the normal is for them, so normal for me is not going to be the same as normal for you, and it's not going to be the same as normal for our patient. So you see what the uninvolved side feels like. Then you're going to go on the involved side and you're going to assess the range of motion and the end feel. This is before you've even picked up the goniometer. You've done all this stuff. So now you have in your mind an idea of where it's going to go. So I like to eyeball it first, and I like to say, is that about 90? Is that about 180? Is that in between there somewhere? So if I kind of eyeball it, say we're doing shoulder flexion, I'm just using that for an example, and I say, okay, well, it's more than 90, but it's less than 180, so that's where I'm going to expect my measurement to be in that range. So it's a really good idea to sort of eyeball it and see what you think before you apply the measuring tool. So then you are going to properly align the goniometer using your landmarks and everything that we're going to practice in lab. There's a download, and I'll have handouts in lab as well of all of the measurements that you will be responsible for, their normal ranges or their average ranges, since there's no such thing as normal. But the average ranges, what the landmarks are, where you put the axis, where you put the moving arm, where you put the stationary arm, and how you're going to align everything. And you will be responsible for that information. So you might want to measure the involved side if it's different from the uninvolved side. So frequently at the initial evaluation, the PT is measuring both sides, and then in the follow-up treatments, the PTA is often just measuring the involved side, or the uninvolved, or sorry, the PTA is measuring the involved side, just to we're not re-measuring the uninvolved side all the time, but it's nice to know that you're going to do that. Okay. So how do you get better at goniometry? Same way you get to Carnegie Hall, practice, practice, practice. So the more you practice, the more comfortable you will feel with it, and the better you will do with it, and the more accurate your measurements will be. So my real hidden agenda goal for you is that when you walk into the clinic on your first clinical, and your clinical instructor hands you a goniometer and says, measure that, you're going to say, I know how to do that. I am so good at that. Plus, for all your other practicals, for your other classes, for your modalities class, you're going to be doing measurements. For your upper extremity and lower extremity orthopedics class, you're going to be doing measurements. For your gait class, you're going to be doing measurements. You're going to get so much practice doing this that you're going to be an expert, and that's exactly what we want to have happen. So we will go over each individual joint in the lab and how to measure it. We'll practice, and you will have your projects that you will do, so you will get to be an expert at one joint right away. And we will have all that before our first lab meeting, and so we will go into lab hopefully feeling really good about goniometry and ready to practice and really gain some skills in it.